I'm an ER doctor, and emergency medicine provides unique insight into human nature, the human condition, and all of what constitutes life. And I think the greatest insight I've learned is that, barring unusual and specific circumstances, given any opportunity, people will not choose suffering. And people arrive in the ER with a range of emotions: fear, angst, sadness, anger. But as the provider, you get to shift their perspective. And it happens from listening, allowing people to get it all out, acknowledging you hear what they say and what matters to them. And then you see something happen right in front of you. And that happens because engagement is the lowest hanging fruit to a path of trust and transformation. And often in those moments, I've asked patients, what would it take for this to never happen again? And over the years, what I've learned is that when people have limited resources, they're making tough decisions every day, asking themselves, do I use my limited resources to pay rent, pay for utilities, buy food for my family, or do I use my limited resources for a copay for a medical appointment, or for a prescription, or for transportation to a medical appointment? And for them, it's an easy answer, because health and healthcare will always rank secondary to survival. And doctors are taught to focus on disease. Doctors are just focusing on whatever's sitting in front of you. So doctors are chasing disease. Patients are chasing life. The two never align. Meanwhile, perpetual cycles of ER visits, hospital admissions, low outcomes, poor outcomes, and high costs persist, because these are downstream consequences of root causes upstream, like insecurities in housing and food and income and education attainment. And for healthcare professionals, this is unacceptable, because it's all related to health. Even life expectancy. For example, the difference in life expectancy between where we are in this room, adjacent to communities of color, and a mile and a half up the street is 30 years. And honestly, personally, it is extremely difficult to repeatedly fix people, reset them to baseline, only to discharge them back to what you know is driving it. Discharge them back to communities that have been disinvested in for decades, which created structural barriers to people being able to achieve at their highest level and greatest desires, which predictably leads to gaps in income, economic mobility, and opportunities to build wealth. But it doesn't have to be this way, and there is light on the horizon. There are conversations going on about this all across the country. In order for us to move forward, we are really going to have to change our mindset about what is possible for people to achieve. And we have to set high bars, not low bars, because where we set the bar becomes a self-fulfilling prophecy. And in order for us to develop innovative, transformative, and sustainable solutions to structural barriers, it's helpful to understand and learn from the historic systems that created them. And we only have to look back at one decade as an example: the 1930s and President Roosevelt's New Deal. Back then, the president was trying to resuscitate the country from the ravages of the Great Depression of 1929. And one of the things he did was to create pathways to wealth building for people. One of the most common pathways to wealth building in our country is home ownership, because of the familial and generational benefits of home equity. So it was a great plan, except in the same decade, the system of redlining was created. Red lines were drawn through communities all across this country. And if you lived behind red lines, you did not have access to that wealth-building pathway. In fact, you were deemed a risk, so it made it difficult for you to access the financial services that would get you to that wealth-building pathway. And the majority of the people who lived behind the red lines were people of low income and people of color. And so at that time, two distinct socioeconomic groups were established and remain fixed to this day. An example of that is the report by the Spotlight team in 2017 that highlighted the median net wealth gap in our city of $247,000 for whites and $8 for blacks. In that same decade, the complicated system of public housing was emerging and evolving. Now, although a well-intended system, I think we missed an opportunity back then to create public housing as a transient stop that was built to enable people to gain the tools and the resources and the stability they would need to subsequently move on to self-sufficiency and financial independence. Instead, regulations associated with some public housing limits the amount of income people can earn without falling off the cliff. In other words, without losing their subsidies in public housing, unless they agree to pay more money to remain in public housing. And I think people understand that's not exactly a financial plan for a way out of public housing. But people wind up finding themselves caught in these sort of inadvertent poverty traps. But again, it doesn't have to be that way. And there is light on the horizon. Now, I work at the largest safety net health system in a geographic area. And let's face it, safety net hospitals have their own cliff effect. But recently, we have been given an opportunity to think about this and ask ourselves, what would it take? And what is our role? Is it charity exclusively into perpetuity, or is it equity? And I'm proud to say we have decided on equity to clear a path to well-being for our patients and communities. We're focusing upstream, targeting root cause to identify opportunities for wealth building, self-sufficiency, independence, and thriving for our patients. We know that healthcare systems should not and cannot do this alone. We know it requires partnerships to leverage assets and resources and strengths. We also know it requires multi-sector partnerships among healthcare, business, foundations, philanthropy, education, grassroots organizations, community-based organizations, community members, and government, so that together we can leverage regulations to achieve common goals. Now, we are in a learning and a nascent stage in this process, but I'd like to share 4 examples of what this might look like. Number 1, we are engaged. We are screening our patients for gaps in determinants of health, and we are connecting them to resources to mitigate and eliminate the gaps. Number 2, in our state, when a healthcare system builds onto its facility or builds a new facility, we're obligated to commit 5% of the total cost to the community, which is great. That's the least we could do. We recently did a campus redesign and requested permission to commit our obligation to multiple housing-related projects. We were granted permission, and it enabled us to invest in a private equity fund that only funds developments that provide access to affordable housing, employment, green walking space, transit, and healthy, affordable food. Our investment contributed to the transformation of 8 acres of blight into what is becoming 323 units of new mixed-income housing, some to own, some to rent. The majority of the laborers at that construction site come from the community. The people in the community said they wanted a grocery store at that site. And we were able to help a grocery store mitigate the cost of expansion by giving it a no-interest loan. We also worked with an advisory group and a planning committee and created the Innovative Stable Housing Initiative. We then partnered with 2 other healthcare systems, and together we invested to fund 3 streams of innovative solutions to housing insecurity. Number 3, we belong to the Healthcare Anchor Network, which is a national collaboration of 45 healthcare systems that focus on building more inclusive, sustainable local economies through healthcare systems being intentional about how they make everyday decisions in 3 pillars: hiring, investment, and procurement. Finally, number 4, the Affordable Care Act requires that hospitals conduct a community health needs assessment with an improvement plan every 3 years. Last year, the hospitals in our city conducted a needs assessment together, which I think set a pretty strong precedent for what's actually possible. And the areas of priority that emerged from the needs assessment and will be a focus of our improvement plan are housing, finance and economic mobility, access to services, and behavioral health. So it's a new day in healthcare and what it means for people to be well. And we have an opportunity. If we can change the healthcare paradigm to partnerships and innovative models of business, it can have a measurable societal impact, a business impact, and a return on the investment that enables reinvestment to achieve sustainability and scale. Thank you. Yeah.